Hello, hi, can you hear me?
I can. Sorry for running a little. It was just an issue I had to go see a wards team about, but
Okay.
I wanted to introduce myself. My name's Tess King. Good to meet you.
Good to meet you too. Hi. Here we
Hi.
are.
Can you tell me, how do I say your last name?
He, just like the pronoun.
Okay, great. Do you want to try to make sure your slide
Yeah.
here? Okay, and then before I let everybody in.
Sure, yeah.
And then I imagine, unless you need any specific moderation from me, I will let everyone in, introduce you, and then I'll just let you take it away, and I can help moderate the chat as well if things come up.
Do you see the slides?
I see the slides. I see it in like it's not in presenter mode.
It's there?
Yes, that looks perfect.
Okay. What I was going to ask, how long do I have for this?
Until 1:30.
Okay. Got it.
And at the end, maybe like 15 minutes to go, I'll probably just put up a link in the chat for the feedback and things like that.
Yeah, how long do people like for questions, or does that vary with the speaker?
I think it varies. I feel like maybe 5 or 10 minutes at the end if you feel like you have that time allotment.
Okay.
But you know, if you want people to ask questions as we go along, you can also totally say that and people probably will jump in.
Okay, sounds good.
All right, I'll let everyone in. Thanks so much.
Thank you.
All right, slowly we're getting a lot of people admitted into our group here. Thanks so much for joining us, everybody. We have a really great talk today, one of our cardiology core teaching conferences with Dr. He. She is a cardiologist over at the VA mainly, and she is talking to us today about pacemakers and bradycardia. I will be helping to moderate the chat, so if you guys have questions and are in a team room or it's hard to unmute yourself, please pop them into the chat. But otherwise, I will let her take it away.
Okay, hi, thank you for inviting me to give this talk on pacemakers and bradycardia. Feel free to jump in if any of you have any questions along the way. I do work primarily at the VA, but also sometimes will do service at Montlake and also work at the Northwest campus. So I have no relevant disclosures. So I wanted to frame this to kind of start with why is relevant to you. There are multiple reasons to pace the heart. The most commonly ones that you're going to see is probably symptomatic bradycardia and kind of one of those umbrella diagnosis. Most of it is due to sinus node dysfunction. You can have atrioventricular node dysfunction, or you can have cardioinhibitory syncope, which is typically neuromediated. So basically, all patients with symptomatic bradycardia should probably be considered to get a pacemaker. And even in patients who are asymptomatic, but they have severe forms of AV block, including obviously complete AV block or second-degree AV block, if you suspect that the His bundle is at the site of the block, for instance, second-degree AV block type 2, or if it's associated with a YQRS complex. So something to indicate that they have distal conduction system disease will make you be concerned and think about a permanent pacemaker. There are certain myotonic disorders, such as muscular dystrophy or Kearns-Sayre syndrome, that will then have progressive AV block in those patients. You should be thinking about a pacemaker. When do you think about temporary pacing? Anytime you have a symptomatic bradycardic patient, but you're not sure whether or not the etiology is reversible, or if you're concerned that there's an infection, those patients usually require temporary pacing or at least a semi-permanent pacer. If a patient has acute myocardial infarction, and they're bradycardic, you would think about temporary pacing. And if they have bradycardia dependent VT like Versad, you would think about temporary pacing. So the bradycardia guidelines from the ACCHA and HRS were updated in 2018, and I'm mentioning some of their decision-making trees. This is a busy slide, but it's quite useful though. it starts for sinus node dysfunction. And first, you have to confirm are they actually symptomatic or not, because the 2018 guidelines really kind of changed the approach, I think. So instead of focusing on a specific heart rate or specific duration of pause, they're more focused on symptoms. If a person has symptomatic sinus node dysfunction, it goes down to this long trajectory. But if they're asymptomatic, you actually should not be putting in a pacemaker. If they are symptomatic, is a class 1 indication for symptomatic sinus dysfunction to think about doing a pacemaker. And then the question of what type of pacemaker to do will then kind of depend. If you're not sure, this is kind of interesting. I think this is underutilized. If you're not sure whether a patient is symptomatic or not from sinus node dysfunction, you can actually give theophylline. And I think, just change this. So theophylline is a medication that can be used as a trial in the study, and if they have a response to theophylline, there actually remains a class 2B indication to actually continue it. Or if they have a response, but they're willing to do a pacemaker, then you would implant a permanent pacemaker. This is the sinus node kind of decision-making tree from the guidelines in 2008. And I think this is a little bit more practical in the sense that you can use this trajectory to determine not just whether or not they need a pacemaker, but what kind of pacemaker and what kind of programming you would need. So for instance, if a patient has sinus node dysfunction, and if they have no concern for AV conduction abnormality, you might even think about programming at AI or AR. I think most of the time it used to be that there was this debate about whether or not patients could be just given a single chamber right atrial pacemaker. A lot of people have gone away from that because of 2 major studies that have compared those pacemakers to dual chamber pacemakers. And they found in patients with a single chamber pacemaker just pacing the right atrium, they're more likely to get atrial fibrillation. And a significant portion of those patients actually eventually ended up needing eventually an upgrade to a dual chamber pacemaker. So this has really been reserved for very select patients. Most patients you will want AV synchrony. And if that were true, you ask, do you want rate response or not rate response? And then if you want rate response, it would be DVDR for rate response, and no response would be DVD for dual chamber pacemaker. We'll go through this nomenclature in a bit more detail, but this is kind of the overview of the decision-making trajectory. Going back again to the 2018 bradycardia guidelines, what happens if you have a patient who doesn't have sinus node dysfunction or AV node dysfunction, but they have conduction disease? So they have EKG abnormalities, whether it's a bundle branch block or fascicular block, or there's something not right with their conduction system. Well, if they have syncope, if they have symptomatic bradycardia, that is a class 1 indication for permanent pacing. If they have conduction disease that is confirmed, so if we do an EP study and you measure their conduction system properties and the time it takes from activating the bundle of His, the time it takes to activate the ventricles, the HV interval is long, then they meet indication for permanent pacemaking. If none of this is true, but they have alternating bundle branch block, that is a indication for permanent pacemaking. And if none of those are true, but they have a depressed left ventricular ejection fraction, and they have a left bundle branch block that is longer than 150 milliseconds, plus they're in heart failure, class 2 or higher, then you have to consider them a class 2B indication for actually CRT. And then if none of those are true, but you have symptoms that suggest intermittent AV block, then you will go down the decision treatment algorithm for AV block. And that is depicted here. Again, this is, I pulled this again from the 2008 guidelines. A lot of it has remained the same, but I think that this is a little bit more useful because, again, it shows you not just, if or when to pace, but also, what type of pacemaker and what type of programming you would do. So practically speaking, I think this is a bit more useful. And I'll just leave that for your reference. So ways to pace the heart. There are several different ways to pace the heart. The most common is transvenous endovascular system. There's also epicardial system. Surgeons love to implant this at the time of, for instance, like a tricuspid valve surgery. There's the leadless pacing system now that paces the right ventricle. And these have no generator. It's actually built into one little device. They have no pacemaker pocket. You can pace in a single chamber in the ventricle. That would be sensing and pacing within the ventricle. You can do it in a single chamber in the atrium, sensing and pacing. Again, this is really kind of fallen out of favor because of a lot of patients eventually ending up needing a dual chamber pacemaker, and also the increased risk of atrial fibrillation in patients who get single chamber atrial pacing. You can do dual chamber sensing and pacing, and there's different kind of leads. The wires can be passive fixation leads. They have tines or fins that basically latch into the trabecula of the myocardium. This makes it a little bit tougher in the future if you were having to think about explanting them. And then there's also the active fixation leads that uses a mechanism, screws, hooks, or barbs to actively be screwed in within the myocardium. And there's a way to deploy it, and there's a way to undeploy it. And it makes it a little bit easier later if you think about explants, because you can unscrew. Theoretically, you can unscrew, although it doesn't always happen. So pacing leads can be bipolar or unipolar. It is obviously, this is the electronics of this topic. Bipolar lead has 2 conductor coils and 2 electrodes in contact with the myocardium, and so it generates a very small current loop. It's about 2 to 3 centimeters to complete that circuitry. Unipolar lead has 1 conductor coil and 1 electrode in contact with the myocardium, and the current flow goes from that through the chest to the pulse generator, and so that creates a very large loop of current because it has to progress from the heart up to the chest to where the generator is. The advantage of the bipolar leads is that there's less muscle stimulation, and so there's less electromagnetic interference, again, because the bipolar circuitry is very small, and bipolar leads can actually usually be programmed unipolar. So there's also that advantage. So if you ever want a unipolar configuration, you could just program it that way. So here are the 2 types of bipolar lead conductors that exist. Most commonly nowadays is the coaxial system. Again, 2 electrodes, 2 wires that are going coaxially, so one looping around the other. The advantage of this is that each of these are kind of insulated separately, so that if you have a break in the insulation for the outer sheath, then this wire might be jeopardized, but you can still program the device unipolar by using just the cathode tip. And so that makes this advantageous. The other design is using co-radial lead design, which there's 2 wires here, and you can see that they are wrapping into this coil kind of simultaneously. They're right next to each other, and they're separated by a very thin polymer of insulation. The disadvantage is obviously once the larger insulation breaks, and then both these are to be jeopardized. But the advantage here is that you actually have potentially a smaller lead diameter. So the basic pacing system is actually using a pulse generator plus the pacing leads. You need to have a pulse generator, and you need to have the wires. The implantable pulse generator houses the battery, and it houses the circuits. And the circuits are typically integrated microprocessor that control the pacemaker. The pulse generator is enclosed in a very airtight titanium case, and the pacing lead is an insulated conductor wire that conducts sends electrical signals to the generator and delivers pacing impulses to the heart. The electrode is still part of the lead. It's just that part of the lead that is uninsulated at the very tip, comes in direct contact with the myocardium. And then on the other side of the lead is a lead pin, also called the connector pin, that connects to the pulse generator. So this is a schematic. So here you have a pacemaker generator, and you have 2 wires in this case. So up here will be the connector pins, and the leads on wires are used interchangeably. They'll go down, this lead ends up in the right atrium, and then this one ends up in the right ventricle. And what they're showing you here is that this is a bipolar right ventricular lead. So you have an anode and a cathode. And so down here, this will be the lead tip. The part that's not insulated is coming in direct contact with myocardium. And the rest of it is the conductor. So how does the circuitry run? So you go from the battery, which is typically now lithium iodine, sends an electrical impulse via the pacing lead to the cathode, which is the tip electrode. And that impulse travels to the myocardium. The impulse then travels through the body, tissue, and fluid, and then the impulse will return back to the anode, which is the ring electrode for bipolar systems. In unipolar systems, the anode would just be your pacemaker generator. The pacing pulse consists of current, which is measured in milliamps of voltage. That is also called amplitude. That's measured in volts, obviously. And impedance is a measure of resistance, and units for that is ohms. So sources of impedance will include the lead conductor, the electrode to tissue interfaces. Basically, anywhere the electricity has to pass through will be a source of impedance or resistance. And then if you recall Ohm's law, where voltage equals to current times resistance of V equals to IR. So just throughout the question, based on this relationship, Ohm's law, what do you think will extend battery life? Anyone? Oops. So to extend battery life is really the measure of the current. What will make I bigger is if you have an increase in voltage, so you can actually capture, and then you have a smaller resistance. So less impedance and increase in voltage that will extend battery life and make batteries last longer. So what are normal values? So battery typically ranges anywhere from 8 to 12 years. That's really good for nowadays for our pacemaker patients. Normal impedance ranges from 200 to 2000 ohms. And whenever you have an abrupt change in lead parameters, like greater than 25 or 30%, you have to think about a lead problem. So if you have a sudden jump in impedance, you think about a lead fracture. And if you have a sudden drop in impedance, then you have to think about like a lead insulation or a lead break. Oops. And then what are typical acceptable sensing values that are listed in this table. So there are lots of things that can be programmed. You can program output threshold, which means how much energy you want to be delivered over what duration of time in order to capture myocardium. And you can also program sensitivity. And sensitivity, the reason you want to be able to program sensitivity is that you don't want to over or under sense. You don't want to over sense things that are not important, and you don't want to undersense important physiological cardiac signals. So here's a point that just to keep in mind. When the sensitivity setting is lower, that actually makes the device more sensitive. So just try to keep that in mind, because it's not inherently intuitive when you initially think about it. But when you think about what the sensitivity setting does, is when you lower the sensitivity setting, it makes the device able to detect smaller signals, and so it makes the device actually more sensitive. All of these things actually nowadays can be automatically programmed. The device is smart in the sense that output threshold can usually be programmed to automatic, and so can sensitivity. You want sensitivity usually to be set to be at half of the sensed impulse, and this can automatically be adjusted again based on periodic sensing tests. So if any of you have ever tried to interrogate a patient with a pacemaker, you can certainly do that. You're not going to, so don't feel that you could inadvertently change something. So most programmers have an interface that you have to hit a specific button, and typically it's called program. So if you don't hit this program button, you're not going to make any setting changes to the device. So it can be useful if you're on call, for instance, and someone has a device and you're curious, or you just call cardiology or call EP. But the programmer, the interface shows up like this. And I just wanted to show you, because through this screen, you can see that you can actually change a wide variety. So you can actually program a lot of different parameters, including the mode, the rates, and the different settings that we talked about, the amplitude, the pulse width, sensitivity, and then whether you want it to be unipolar or bipolar, you can change the different configurations. So again, many parameters can be programmed. The more salient, important ones are probably rate response. This can be on or off. And this is modulation of pacing rate in response to input from sensors that measure specific physiological parameters. Now, when rate response is programmed on, there are additional settings that can be adjusted, and those include the activity threshold, how much rate response slope, and how quickly, which is the reaction time, rate adjustments can actually occur. Atrial tachy response can be programmed on and off. This allows the pacemaker to automatically switch from an atrial tracking to a non-atrial tracking mode, and that prevents atrial tracking when there is, for instance, SVT or atrial fibrillation. And of course, the pacemaker mode, which is this generic standardized coding for what the pacemaker is actually doing. So most pacemakers
Can I interrupt you just for a second?
Yeah, please.
There are just a couple of questions in the chat.
Yeah.
The first is how is it that how does battery life impacted by the amount of pacing provided?
Yes. So if a pacemaker is pacing continuously, theoretically it draws a bit more battery. Although these days, because batteries are designed so well, it makes very little impact. It really is when the pacemaker is set at a higher output. So if they're being paced and it's not, for some reason, you can't program to automatic threshold, what that means is they're set at a certain amount of volts delivered to be over a certain amount of time. When that number is high and that's chronic, it will drain the battery. As an example, I recently had a patient who came to me for a battery change only after 4 years. He has a cardiac resynchronization device. So he actually has 3 wires. Is a pacemaker only, but his left ventricular lead actually was draining most of his battery because it had to be programmed at 4 volts over a pulse width of 1.2 milliseconds. And that battery only lasted 4 years, where otherwise it should have lasted 8 to 12 years.
Great, thank you so much. And then the second question that popped up is, what is the clinical significance of bipolar versus unipolar leads?
The clinical significance. So I think the clinical significance, so most leads nowadays are bipolar, first of all, but the clinical utility of being able to pace unipolar is helpful when you want to troubleshoot. If you have a change in impedance, or if you have noise, and you're not sure where the noise is coming from, you can actually change the sensing and the pacing configuration. So it paces from either the tip electrode, which is the cathode, or the ring electrode, which is the anode, and then you can program from either one of those back to the generator, which is basically the other end of the circuit. So if you do that, you can try to pinpoint, is there something wrong with, for instance, those coaxial leads that I showed earlier? Is there something wrong with the inner insulation, or is there something wrong with the outer insulation? And I think that's what most people think of using unipolar configuration for. There are also some instances where you can get stimulation of muscle when the person is programmed a certain way, and again, having the ability to change those configurations can be useful when you try to troubleshoot that.
Perfect. Those are all the questions so far.
Okay, great, wonderful. Yeah, any more questions? Feel free to just speak up or to put in the chat. So these are this is the configuration for determining what the mode is in. So you often hear about these 3 letters like VVI or DDD. So the first letter tells you which chamber is paced. Is it the atrium, the ventricle, or is it both? The second letter will tell you which chamber is sensed. Is it the atrium, the ventricle? Is it both, or is it none? The third letter tells you what is the response of the device. What is it supposed to do after it senses a signal? Does it inhibit pacing? Does it trigger pacing? Does it do both, inhibit or pace? Or does it do none? And then the fourth letter, which is basically on and off binary kind of letter, is a rate adaptive mode. Is it on, which is R, or is it not on, which is O? So this is kind of the schematic. A better way probably represented is, I call this Medtronic. So what you can see, the first letter is for pace, the second letter is for sense, the third is for response, and the fourth is for rate. So if you look at the table down here, these are the options, and what's highlighted in blue are the most common types of pacing configurations. So you would pick one in the blue here, one in the blue here, one in the blue here, and one in the blue here. And again, if different combinations of that will give you different pacing configurations. So as some as an exercise of the mind, I guess, I'm curious, what mode do you think you would use if you had a patient with 3rd-degree heart block? Any takers? So if a patient came in and presented with 3rd-degree AV block, what do you think you want the chamber to be paced?
There's a vote in our chat for DDDR.
Perfect, DDR, perfect, yeah. So you want to be able to pace at least the ventricle, right? And it would be nice to pace the atrium, and also sense both chambers, and then have the ability to pace when you don't sense, and also to inhibit when you do sense. And the rate modulation is useful. And then what mode would you use if the patient had sick sinus syndrome? So in theory, if it only has sick sinus syndrome, you can, and presuming that they had intact AV conduction, you can pick AAI. So you can have pacing the atrium, sensing the atrium, and inhibit when you sense, AAI or AIR. In practice, though, because of the two studies I alluded to earlier, most people will have will basically pick a dual chamber pacemaker in this sense, but be able to program AI and then have that mode switch to DDD if that's needed. And for Medtronic, that would be MVP pacing. And then for permanent atrial fibrillation, which mode would you want the pacemaker to be in?
There's a vote for, a couple votes for AAIR.
AAIR. Okay. So, and if a patient has permanent atrial fibrillation, the atrium is firing chaotically, spontaneously, and very, very rapidly. The ability to actually pace the atrium when the atrium is in fibrillation mode is extremely, extremely unlikely. So AIR would not be the right way to pace a patient in permanent AFib. In patients with permanent AFib, the reason that they most commonly need a pacemaker is, for instance, if you want to rate control them. And you're limited in rate control because if you put them on too much rate controlling agents, they can have periods when they get really bradycardic. And so, classically, those patients are called tachybrady syndrome patients. And so the reason they would be getting a pacemaker is actually because you want to have some kind of backup pacing in place. And so at the very minimum, in patients with permanent AFib, they should have the ventricle being able to pace. So that first letter needs to be a V. Whether or not you want atrium to be paced, depending on, do you think they will ever have a chance of getting sinus rhythm? If by definition for permanent AFib patients, these patients are basically the decision made between the provider and then the patient that they're going to actually be left in atrial fibrillation. These are usually patients who tried multiple ways of rhythm control and have either failed or they've already presented to you at a later stage in the course of their atrial fibrillation to the point where rhythm control is no longer a feasible option. So the pacing mode that you would use for patients with permanent AFib would actually be VVI or VVIR. Okay. So single versus dual chamber. So in patients with sinus node dysfunction, a single chamber, this will walk you through what happens if they get a single chamber ventricular pacer, or what happens if they get a dual chamber pacemaker. So in sinus dysfunction, you have a P wave here, and then you have a QRS, and then you have ventricular repolarization, another P wave, a QRS, and then ventricular repolarization. And then you have a pause. So the sinus node is not firing, or if there's sinoatrial exit block. So in these patients, if they get a single chamber ventricular pacemaker, what happens is that you have a P wave, a QRS, and then here's another P wave, a QRS. And then when this is the last sensed QRS, this will trigger a low rate timer. The low rate timer will start, the clock will tick, and then it's going to go on to whatever that lower rate limit you set for the single chamber pacemaker to be. And then when it hits that timer expiration, it's going to activate the pacemaker to pace. And then you're going to have, because it's a single chamber ventricular pacemaker, you're going to have a ventricular pace beat. And here in graphically is the representation of retrograde P wave, which you may or may not see. And that's what the single chamber ventricular pacemaker will do in the patient with sick sinus syndrome. When they have a dual chamber pacemaker in the same patient, you have a P, a QRS, a P, a QRS. Now, when you have the last sensed P wave, because it's a dual chamber pacemaker, so it has an atrial lead, when you have a last sensed P wave, it will start timer. And then when you have a last sensed R wave, it will start another timer. And so in pacemakers, it's all about timing. And both of these timers will go on the same time. And so this first little timer is actually the AV delay or the AV interval. And this interval is most similar to what we think of as the PR interval. And then it will also start the low rate timer. And then when these timers expire, that's when you're going to have the next pace beat. In this case, because this is only sinus node dysfunction and presumably the patient has intact AV conduction, what happens is that the last sense R is within, it falls within before the AV delay actually expired. And so when you pace the next beat, this triggers again the AV delay, but then you have a sensed R within that time interval, so the ventricles are not being paced. Now you compare that to a patient who has complete AV block, so third degree AV block. What you see is you have, here's a P wave, here's a QRS plot, probably a junctional escape because this is too narrow of an interval. This is ventricular repolarization. Here's another P wave, but you can see that there is no QRS here because there's AV block. And then here's another QRS, and this is probably a junctional escape beat. You can see embedded within the QRS and T wave here is another P wave. So in these patients, if all they got was a single chamber ventricular pacemaker, what happens is that at the very last sensed R beat, you have a low rate timer that starts. And then when that expires, you get a pace beat from the ventricle. And then the pace beat, from that very last pace beat, you have another low rate timer that starts. And within this interval, if there is another sense QRS that's intrinsic, it would inhibit the pacemakers and that's pace beat. But because there isn't, then the next pace beat comes, and the interval between these two is determined by the low rate, whatever low rate you set the pacemaker to be. In these patients, if they have a dual pacemaker or dual chamber pacemaker, what you will see is when you have a P wave here, it starts AV delay. But here, because you have a sensed R wave, even though this was actually not conducted from this P wave, but nonetheless is a sensed ventricular impulse, that actually inhibits ventricular pacing. And then the next P wave comes up, and then here you can see that this arrow is longer than this because the AV interval here is longer. And so it actually expired the AV interval, and you still didn't have an intrinsic QRS complex come in. So the pacemaker, when that timer expires, it will give it a ventricular pacing impulse, and then so on and so forth. So the benefit of dual chamber pacemaker is obviously you maintain AV synchrony, whereas in single chamber pacemakers, you don't have that. Let's see. Okay, so going through some of kind of these common modes. So in the mode of VVI or VVIR, again, this mode paces the ventricles at the end of the lower rate limit when there is no sensed V beat, and it paces and senses only in the ventricle. It will inhibit when there is a sensed ventricular beat outside the refractory period. And again, it's time from each QRS, whether it's paced or if it's intrinsic. The lower rate limit is the longest time that is allowed before delivery of the pacing impulse and is set by the programmed lower rate. So for instance, if you have a patient with a pacemaker setting to VVI 60 beats per minute, what is the lower rate limit? So if you start out with 60 beats per minute, and you want to get a lower rate limit from this number, how would you go about doing that? So it's, I don't have the chat. I don't know the chat one. It's a little bit of, just a little bit of math, but so if you started with 60 beats per minute, and you want to get to a number that ends up in milliseconds, because that's what the lower rate limit is, you would take basically 60,000, because there's 60,000 milliseconds in a minute, divided by 60 beats per minute. And so the lower rate limit in this case will be 1,000 milliseconds. Now, when you have a patient who has AI or AIR, I don't think you're going to see this as frequently anymore, because people tend not to implant devices with just this. But for MVP mode, so a patient can actually present in this mode with a dual chamber pacemaker. And in this mode, despite having a dual chamber pacemaker, they will be only pacing the atrium at the end of the lower rate limit when there is no sensed A. So just like VVIR, where it senses and paces the ventricles, AIR will sense and pace only in the atrium, and it inhibits when there is a sense atrial signal outside the refractory period. This is time from each P wave, as opposed to QRS. So this is a question that I kind of presented earlier, but what rhythm should the patient have in order to use AAI? And traditionally, there's this kind of debate that theoretically patients with just sick sinus syndrome, patients that have intact AV conduction, you should consider AAI pacing. And in actuality, people have really gone away from that. So nowadays, practically speaking, you really only reserve AAI, purely AAI single chamber pacemakers in patients who have maybe congenital sinus node dysfunction and intact AV conduction. This is a term that you may hear about pacemakers, which is hysteresis. Hysteresis promotes intrinsic cardiac activity when the heart rate slows. What that is that hysteresis is basically another programmable parameter. It's a rate that you can set. So in addition to the lower rate limit, you can set hysteresis to a rate that is lower than the lower rate. And this will suspend the lower rate limit. That means it will basically bypass the lower rate limit to allow slower pacing. And the whole point is to promote intrinsic pacemaker activity. Hang on 1 second. Okay. This is probably by far the most common mode, which is DDD or DDDR. This paces and senses both chambers. There's two timing intervals. There's the AV interval and there's the VA interval. And then the AV interval will start after each atrial event, and then the VA interval will start after each ventricular event. And I'm gonna skip these details in the interest of time, but feel free if anyone has questions to ask them or reach out to me later. And DDD has multiple refractory periods. And then DDD also has multiple blanking periods. But the refractory periods are all designed because you don't want to sense certain signals after a V-sensed or V-pace beat. Any idea what kind of signals do you not want to sense after a V-sensed or V-pace beat? Yeah. So one common signal that you might end up seeing is that you actually don't want to sense T waves. If you sense T waves, and sometimes on telemetry, people will call you and saying patients in tachycardia, but when you get there, they're actually not in tachycardia. Even telemetry machines can get fooled. If they count the T wave as a V-sensed event, then you're essentially double counting. And it actually, in a pacemaker, that becomes important because you can actually be inhibiting pacing if you sense it as if the pacemaker thinks it was an intrinsic V-sensed event. So you don't want that to happen. You don't want to sense T waves, oversense T waves. The other thing that you don't want to sense is retrograde P waves, because that can actually lead to what's called pacemaker-mediated tachycardia. If you're pacing the ventricle and you have retrograde P wave, but the pacemaker is acting on this retrograde P wave, then it keeps on pacing essentially to a signal that is self-created. And that's really essentially what pacemaker-mediated tachycardia is. There's multiple blanking periods, as I said before. Blanking periods, unlike refractory periods, blanking periods are not programmable. And several of these blanking periods, again, I don't have the time to really go into detail here, but the bottom line of programming the refractory periods and then changing the atrial rate limit or the lower rate limit, excuse me, and the upper rate limit to see what you get in terms of the blanking periods is again to avoid over and under sensing. And then there's this very unique mode, VDDR, and this is a mode. There's a very special lead. It's a single lead that actually has the ability to pace the ventricle, but sense both chambers. So second letter is for sensing. So it actually senses the atrium and it senses in the ventricle. And this is quite a unique lead that is available through Biotronic. And this lead allows the device to promote AV synchrony essentially, but it does not allow for atrial pacing because again, it only has the option to pace in the beat. So again, this paces on the ventricle but senses both chambers and avoids pacing the atrium. And then there's DDI and DDIR modes. This paces and senses both chambers, but it does not track, which means is that if you sense the A, it only inhibits the scheduled pace interval. That's what the I is, but it does not start the sense AV interval. So if it started the sense AV interval, that means it will be tracking and it will be pacing, but it doesn't do that. It only inhibits, it does not trigger pacing. This is suitable for patients with intact AV conduction, but this does not provide AV synchrony when the atrial rate exceeds the lower rate limit or the sensor indicated rate in DDIR. So what that means, if the atrial rate is too fast, it exceeds both the lower rate limit and the sensor. By sensor, I mean if it's rate responsive, so that's what the R is. The sensor indicated rate is typically higher than the lower rate limit. But if the atrial rate is too fast, then this mode will not allow for AV synchrony because it can't track the atrium. And then there's asynchronous modes of pacing, which is AO, VOO, and DOO. This is pacing that occurs at very fixed intervals, and it's for use during surgery, during radiation treatment, during emergencies, during MRI, or magnets. You can apply a magnet over most pacemakers, and it will go into an asynchronous pacing mode. So that's good to keep in mind in emergency situations. So single chamber pacemakers can lead to pacemaker syndrome. And what is pacemaker syndrome? So in a single chamber pacemaker, we have loss of AV synchrony, and or if you have retrograde VA conduction, this can lead to pacemaker syndrome. And this can be very symptomatic for patients. So what happens is during either sinus pause or AV block, low rate timer starts after the last sense QRS complex. And then that can lead to a retrograde P wave. And the retrograde P wave will cause a rise in atrial pressures. And that's what you see when you do the physical exam, you see Canon A waves. VA conduction is less likely in AV block. So the pacemaker syndrome is more common from a single chamber ventricular pacemaker in patients with sick sinus syndrome as opposed to AV block. Now, the pathophysiology is that you get neurohormonal reflexes that causes peripheral vasodilation and hypotension, and patients will feel it. They can present with syncope, presyncope, chest pain, weakness, lightheadedness, orthopnea, PND. The incidence of pacemaker syndrome ranges from under 2% in the Danish mode selection trial to as high as 18% in the mode selection trial in sinus node dysfunction. So what should you do if a patient has pacemaker syndrome? You should call cardiology or call EP. And what are they going to do if a patient has pacemaker syndrome? Yeah, so to restore AV synchrony in patients who have pacemaker syndrome, they need another lead. So they need to upgrade to a dual chamber pacemaker. So potential problems with dual chamber pacemakers. So you can have pacemaker mediated tachycardia, which I mentioned before. You have a retrograde P wave that's repetitively being sensed and triggering ventricular pacing. It basically goes into a cycle. And these patients will typically present paced in the RV at the upper rate limit. And the possibilities there are they either have PMT or they fortuitously have some kind of an atrial arrhythmia right at the rate of the upper rate limit. You can adjust the refractory periods, this thing called the post-ventricular atrial refractory period, PVARP, and that can be adjusted so that the sense P waves fall into this refractory period and is counted as an atrial refractory sense beat. And when it falls into the atrial refractory period, the pacemaker does not pace off of that. And so you can extend PVARP to treat PMT. Another thing that you can encounter in dual chamber pacemakers is 2-to-1 or higher level pacemaker blocking pattern. So if the P wave falls within another refractory period, this is a total atrial refractory period, ventricular pacing is blocked. And so if your atrial rate is suddenly all of a sudden very fast and exceeds the rate that's set by the total atrial refractory period, then you will see behavior such as 2-to-1 block or even higher levels of block. I'm going to skip this math here. And then let's talk a little bit about pacemaker emergencies in the last segment of this talk. What are some emergencies you could encounter? Failure to capture, failure to sense, oversensing leading to pauses in pace rhythm or rapid trigger ventricular pace rates such as PMT, or the pacemaker doesn't have any output. And so the first thing you do, in addition to calling cardiology, calling EP, getting a device interrogation, is you want to get a chest X-ray. And what do you look for on the chest X-ray? You look for lead positions, you look for lead configuration, if it's unipolar or bipolar, you look for the generator position, you try to see what the generator is on chest X-ray, although that might be too specific. And you look for connector integrity. By connector integrity, you look at the lead, the wire from the generator all the way down to the tip, and you see if there is any breaches in insulation that you can appreciate on chest X-ray. So you look for lead fracture, you look for lead insulation defect, and then if it's a new implant, a fresh implant, what you also want to pay attention to on the chest X-ray is the presence of pneumothorax. And so this is an example of a pneumothorax after a new pacemaker implant. So here, pacemakers are traditionally implanted on the left side more commonly than the right because most people are right-handed. And the point of access for pacemaker wires are typically 3 different choices. You have subphallic vein, you have the axillary vein, and then you have the subclavian vein. Cephalic has virtually no risk for pneumothorax. Axillary has less, still probably no risk if it's truly axillary. And anything into the subclavian, so beyond this landmark, so here's the clavicle and this is the first rib, beyond this landmark will be subclavian vein. And when you enter the subclavian vein, you have an increased risk for pneumothorax. And here's an example of a moderate-sized left pneumothorax. So how do you troubleshoot? Why does it not capture? Why does the pacemaker not capture? It could be that the tissue is in refractory phase. It could be because the lead got dislodged or perforated through the myocardium. It could be that there's an increase in myocardial stimulation threshold, which could be physiologic, pathologic, metabolic, drug-related, a number of different things. It could be lead insulation break. It could be programmed too low of an output. If the stimulation threshold had risen, because of whatever other factors, and you're not programmed the high enough output, you're not going to capture. Or it could be that the battery is dead, generator is at end of life. And what can cause undersensing? If you have a cardiac impulse, but the pacemaker is not picking it up, it could be because it's a very poor intracardiac signal. The intracardiac signal can be occurring in pacemaker refractory period. The lead can be dislodged. You could have insulation failure. You could have a conduction wire fracture. Now, what can cause oversensing? Physiologic intracardiac signals can cause oversensing, like T waves. You can sense T waves, or R waves, oversensing of, so you can have crosstalk, basically. You can be sensing far field signals. So if you have an atrial lead, but it's sensing R waves from the ventricle, you could be oversensing that. Or concealed extrasystoles. If there, so in anything in electrophysiology where you don't see the signal, we tend to call it concealed. So concealed extrasystoles is basically the ventricular myocardium is firing, and it could be a very focal area that's firing. And that is what the pacemaker is sensing and inhibiting it, and that could be a source of oversensing. Physiological extracardiac signals can always be a source of oversensing, and these include muscle potentials. And then, of course, it could be EMI or just noise. So when do you use the magnet? You can use the magnet to assess for capture. You can use the magnet to break PMT, other causes of high rapidly paced ventricular rhythms. You can use a magnet to treat crosstalk inhibition, to treat oversensing so that it goes into an asynchronous mode essentially, and it's not sensing. Because when you put a magnet on most pacemakers, it will go into AOO, excuse me, or VOO or DOO, and it will only pace at whatever chamber it's told to pace, and it will not sense to anything, nor will it inhibit, nor will it trigger pacing. And so going forward, so these are some common drugs that patients may be on that alter pacing threshold, and this is listed here for your reference. Here is an example of Initially, when you look at this tracing, you wonder what is going on. Is there a delay? So if you just look at lead V2, this could almost pass for maybe a atrial pace, ventricular sensed rhythm. But if you put it together, this is another lead of the EKG. You can actually see that, oh, this is actually pacing in the ventricle. But what is actually going on? If you look at the whole kind of the rhythm strip, this is hyperkalemia. This is an example of undersensing. So here on the top is ventricular fibrillation, essentially. But then you can have these intermittent spikes. These are actually pacemaker spikes. And down here, this is ventricular tachycardia. And you can see that the pacemaker is undersensing the VT and is trying to pace. So pacemaker pearls, I'm just going to leave you with a couple slides on the pearls of pacemakers. So in dual chamber pacemakers, T waves are sensed and used to trigger two timers, the low rate timer and then the atrioventricular interval or the atrioventricular delay. So two timers in dual chamber pacemakers. When the low rate timer expires, an atrial stimulus is delivered. If there is intrinsic AV conduction, there is a sensed R wave before this atrial ventricular interval expires, and the ventricular output is inhibited. During AV block, and you have no escape beat, there is no sensed R wave, this atrioventricular interval expires, and then the ventricular stimulus is delivered. So that means it's actually paced. Most pacemakers will use a 4-letter code, and the first 3 letters are the most important ones. Again, paced, sensed, and response. Most pacemakers will have an RV lead. Therefore, on a 12-lead EKG, they will have a left bundle morphology. And if you think about that, if you're pacing the RV first, it will be as if you're racing down the right bundle first, and it gives you the appearance of a left bundle block. So if you see a right bundle branch pattern in the patient who is chronically paced from RV, either they have a CRT device, so they're actually pacing from both the left and the right ventricles, or you have to think about ischemia or some additional intrinsic conduction abnormalities. If a patient has a pacemaker and it comes in with a pericardial fusion, you think about and evaluate for a lead perforation. When you see a fusion beat on a pace EKG, it is basically a hybrid of the intrinsic and the pacemaker-induced rhythms. If a patient has a recent pacemaker and they have loss of capture, you want to get a PA and lateral chest X-ray and a limited echo to assess for pericardial fusion. If there's concern about lead perforation, you want to get a CT chest with no contrast. The early complications after a pacemaker implant include pneumothorax, hemothorax, pocket hematoma, lead dislodgement, thoracic duct injury, and brachial plexus injury. The late complications will include the pacemaker infection, usually is local, but sometimes the treatment will require explant if they have infected endocarditis. AV fistula is something you want to think about, and then lead fracture. And that's it. So happy to take any more questions or comments. And then I was asked by Tess to put this, this QR code here for the feedback survey. You guys still there?
I'm just looking for questions in our chat box. Thank you.
Okay. I hope this was helpful. There's, you could spend a long time on pacemakers and bradycardia. And if there's something that I didn't address and you want more in-depth information on, feel free to email me.
Perfect. Well, I'm not seeing any additional questions, but thank you for letting us jump into the chat or into the talk a couple times to ask some questions that came up. Thank you so much for including the feedback survey as well. And if everybody could be sure to take a snapshot of that with your phone and just fill out our survey, that would be great so we can keep great speakers coming back. Thank you so much, Dr. He.
Okay, thank you. Take care. Take care, guys. Bye.